Okay, so to start with, you are all aware that the heart failure syndrome involves different organ systems. We know the cardiorenal syndrome, kidney insufficiency, heart failure patients often also present with thyroid dysfunction. They suffer from anemia because the bone marrow function is suppressed. Many of the patients do also have a skeletal myopathy and problems with their muscles. And we don't really know, at least as cardiologists, we don't really know how heart failure affects the brain, and this should be the theme of my talk. So if we go back 35 years, we find the first mentioning of cardiogenic dementia here published in the Lancet. And here they state it's not a very sympathetic case for the doctors. They say it generates an unsympathetic response from doctors if such patients are presenting. But they realized at the time that a mild dementing state has become much more severe in the presence of physical illness, such as bronchopneumonia and heart failure. So this was the first mentioning that heart failure could be involved in cerebral dysfunction. So if you look at the prevalence, we heard it previously by Dr. Kovac, there are different mentionings. They go from 1/4 to 50% of affected patients. It really depends how you measure it. We heard also that the mini-mental status is very important to diagnose this condition in the patients. So in the Time CHF study Hans-Peter Bronner did in Basel, we saw that about 10% of the patients that were included in this study had a significantly cerebral dysfunction. But what is interesting about these patients that are affected, only 20%, well, I have to say, the physicians know about only 20% that they are affected. So the physicians don't realize that the patient has cerebral dysfunction. And if you compared age-matched people without heart failure with people that have heart failure, one thinks that the relative risk of a person that develops heart failure for cerebral dysfunction is about 60%. So these are the factors that are associated with cerebral dysfunctions in heart failure patients. Obviously, age is a factor, but also female sex. More symptoms, higher NYHA class are associated with cerebral dysfunctions, higher heart rate, anemia. There are some discussions about depression and BNP, so some papers say depression is associated and also BNP, but others don't say this. So there is some controversy about this. But for sure, if a heart failure patient suffers from cognitive dysfunction, we know that he has a worse prognosis. So these are data from patients that were hospitalized because of heart failure, and as you can see, those with cognitive dysfunction had a worse prognosis than the ones without. And what was interesting, the hazard ratio really increased with the degree of cognitive dysfunction. This is also true for long-term survival, and these are again data from the Time CHF trial. We saw there that even after 4 to 5 years, there was a significant increase in mortality in the patients that suffered from cognitive impairment, with an increase in relative risk of about 50%. What domains are affected, and we also already heard that from Dr. Kovac a little bit, it's mainly the memory, short and long-term memory, mental flexibility. The executive functions are affected, and that is, I think, important for patients with heart failure. Also language and attention. And if you look at all these domains, you can imagine that if these domains are affected, that this could really limit the ability of a heart failure patient to perform self-management. So it is an important issue in clinics. It is always discussed whether really heart failure is the reason for the decline of cognitive dysfunction, or is it just the cardiovascular disease burden these patients have. And this is a nice study published in the European Heart Journal, where they compared patients with heart failure, this in orange, brownish, and patients with ischemic heart disease but without heart failure in blue. And as you can see here, the patients with heart failure, they did even worse than the patients with ischemic heart disease in different domains. These are mainly memory domains, and these are executive functions. So really suggesting that the heart failure syndrome adds to the decline of cognitive dysfunction. Also, if you look at the neuropathology in the brains of patients with chronic heart failure and compare these pathologies with patients with ischemic heart disease, we see that loss of gray matter is present in areas different from the loss of gray matter in patients with ischemic heart disease, here depicted in blue, patients in ischemic heart disease, and in red, patients with heart failure. So it's a distinct pattern of the neuropathology. And if you look at specific areas of which are important for executive function and memory, such as the putamen, we also see that these regions are affected. They are atrophied, they have a loss in gray matter, so they are here. The volume is decreased in patients with heart failure compared to controls on the left side as well on the right side, and the same is true for the corpus mammillaria, shown here. A control patient, this is a patient with heart failure, so the volumes of the corpus mammillaria, which is important for memory function, is significantly lower, the volume, compared to controls. This is also true for the fornix area. So we see distinct volume reduction in patients with heart failure in the brains. So the question is now, what is at the core of this? What is the pathophysiological mechanism? And here I would like to share with you an animal study that was investigating how lower cardiac output affects brain circulation. So here they did infarctions in mice, and the bigger the infarction was, obviously the lower the cardiac output was. And this correlated also, infarct size correlated also with cerebral perfusion. And as you can see here, infarct size, the bigger the infarct, the higher the cerebral resistance was. And this is suggesting that really the autoregulation of the cerebral transfusion is affected by low cardiac output. And if you put this into the clinical setting, in patients with heart failure, we see here that a higher NYHA class is really associated with lower cerebral perfusion, and the same is true with a correlation here for higher BNP values in patients with heart failure, that it goes along with a global deficit of cerebral perfusion. And to put this a little bit together, I propose such a scheme to understand a little bit the pathophysiologic reasons for cognitive dysfunction. I think it is important that we have reduced cardiac output. This is an important factor. Of course, many of the patients have concomitant cardiovascular risk factors, diabetes, hypertension, that play into this. And altogether, both of these syndromes, they come along with oxidative stress, neurohumoral factors, inflammation, vascular stiffness. They tend to have atrial fibrillation. And this package altogether leads to a disturbed autoregulation of cerebral blood flow and increases the risk for microcardiac emboli and microinfarction. This again leads to structural brain changes, atrophy, which could be really nicely documented by MRI scans and microinfarcts, and ultimately this leads to cerebral dysfunction. So now, I think for us clinicians, it will be important to do something good to these patients, and the question is now, can we improve the cognitive function in a patient with heart failure? And in order to do that, if we think along the scheme I just showed you, it will be important to have therapies that increase cerebral blood flow and to prevent cardiac emboli. And we know from many therapies in heart failure that they increase cerebral blood flow. So first of all, it's the ACE inhibitors and beta blockers were shown to increase cerebral blood flow. Exercise training, we just heard from Dr. Kovac, is very important also to increase cerebral blood flow. Cardiac resynchronization, and of course device therapy and heart transplantation. So in order to prevent cardiac emboli, we know that we should prevent AFib in our patients, and if they are in AFib, we should anticoagulate them. And there is still some sort of a question what we should do with patients in sinus rhythm with very low ejection fraction, and I come to this in a few minutes. Now, let's look at ACE inhibitors. What are they doing to our patients in terms of cognitive function? So this is a study where heart failure patients were studied before the treatment with ACE inhibitors and then after the treatment. And as you can see here, the initiation of ACE inhibitors in heart failure patients improved the odds ratio that cognitive function improved in a dose-dependent way and in a time-dependent way, suggesting that our patients profit from ACE inhibitors not only in terms of their heart function, but also in terms of their function of their brains, and it's also a dose dependency there. These are data from patients that were undergoing LVAD therapy as a bridge to transplant. And here again, the patients improved their visual memory capacities undergoing LVAD therapy, and they got faster in executive function, so they improved their ability for executive function by undergoing this VAD therapy. And here are some data from transplant patients, and this is not cognitive function, this is cerebral blood flow. As you can see here, this is a patient before a transplantation, intracranial blood flow, Doppler pattern, and this is the blood flow after transplantation, increased cerebral blood flow, which goes along with improved cognitive function, and this is a summary of all the patients studied here in this study. So again, these are the things we can do to improve cerebral blood flow and to improve cerebral function in our patients. And so in the last part, I would like to go into the problem of thromboembolism in heart failure, because microinfarction is also an issue that comes along with heart failure. So if we look at the incidence of thromboembolism in different studies involving heart failure patients, we see that it goes from 5% roughly to 2%. But what is important is that in these patients here, about 50%, half of them had AFib, and we know that this is a risk factor for emboli. But if you look at the SCOT-HEFT studies where patients with AFib were excluded, we have a risk of about 2%. And the question is now, what is if the patient has a really reduced ejection fraction? And we have data from patients that have an ejection fraction below or equal 20, that this is increasing the risk for thromboemboli compared to patients with ejection fraction between 20 and 30%. And as you know, a few years ago, the Vorsitz trial tried to address this question, whether we should anticoagulate patients with low EF in sinus rhythm. This study included patients with an EF of 25%, with the primary endpoint ischemic stroke, intracerebral hemorrhage, and death. and had two groups, one group treated with aspirin and the other with warfarin. And as you can see, the primary endpoint was negative. But if you look here, after 4 to 5 years, you recognize that the curve are spreading a little bit in favor for warfarin. And also, if you look at the hazard rates, you see that the hazard rates after 4 to 5 years are better for warfarin compared to aspirin, suggesting that maybe those patients that are good under warfarin, especially during the first time, that they might profit from a warfarin therapy. But in the heart failure guidelines, it's still not a statement to anticoagulate patients, even if EF is 20% if there is sinus rhythm. So with that, I would like to conclude that cerebral dysfunction is prevalent in patients with heart failure and affects up to 50% of patients. Heart failure is associated with structural damage in distinct neuroanatomical regions with cerebral hypoperfusion and microinfarcts as the underlying pathophysiological mechanism. And all the current medical and device therapies we use in daily practice may improve cerebral perfusion and cerebral dysfunction. Thank you very much for your attention.